Hello everybody, my name is Philip Helliwell. I'm a rheumatologist from Leeds in the UK and a past president of GRAPPA. And it's my great pleasure to welcome you to the GRAPPA Spartan Global Education Virtual Seminars for 2021. These will cover psoriatic disease, the peripheral arthritis, the skin, and the axial aspects. This is the first of 6 seminars over the course of the year, and it's the second edition of it. The first edition was on Tuesday for the North and South Americas. It was blighted a little bit by an internet outage, but a very successful meeting was had. And we hope that you'll be able to join us in this meeting by having discussion in the chat sessions that will occur after the presentations. Next slide, please. So this is our agenda today. We have some patient research partners working with us, and we'll hear from Wendy Oldster, who's a patient research partner from the Netherlands, and Suzanne Grieb, a patient research partner from the US. And then I'll give a short presentation on psoriatic arthritis, clinical features, epidemiology, and classification. And then, as I mentioned, we'll have a panel discussion between myself, Wendy, and our other 2 speakers and discussants, Dennis Podobny and Laura Savage. Following that, we'll move on to the psoriasis presentation, which is given by April Armstrong, who's Professor of Dermatology and Director of the Psoriasis Program at the University of Southern California. And we'll have a panel Q&A discussion after that in a similar manner. And finally, we'll discuss the axial aspects of psoriatic disease. And the presentations will be given by Professor Mohammed Asim Khan, who's Professor Emeritus at Case Western University in the US, and Dennis Podobny, who's Professor of Rheumatology at the Charité Hospital in Berlin. Again, we'll have a discussion following that, and I'd be grateful if you think of any questions during the presentations that you put them up for the chat at the time. So, like any seminars, we'd like to have some questions that show your knowledge and whether it improves with the presentations. I'd like to thank Pfizer for supporting this, and then we'll move on to the first of the MCQ questions to do with psoriatic arthritis. So you can click on the answers on the left there in those boxes. The question is, which of the following statements is true about enthesitis in psoriatic arthritis? And the options are: is prevalent in about 1/3 to 1/2 of cases, clinical assessment reliably correlates with imaging, enthesitis is always the initial clinical manifestation of this disease, tenderness at multiple enthesitis points may cause confusion with a diagnosis of fibromyalgia, and finally, enthesitis is most commonly seen around the knee. So make your selections now. There may be more than one correct answer. I'm going to close this poll in 5 seconds. 5, 4, 3, 2, 1. And these are the answers to the polls. We have 42% voting for answer on prevalence of about 1/3 to 1/2 cases, and 44% identifying the confusion with fibromyalgia. So that's an interesting answer, which we'll come back to later. The next question, please. The next question is about the pathology of dactylitis. And the main pathology is it tenosynovitis, bone edema, synovitis, enthesitis, or all of the above? So make your answers now. I'm going to close the poll in 5 seconds again. 5, 4, 3, 2, 1. And interestingly, about 1/3 have chosen tenosynovitis, but the majority all of the above. And again, we'll come back to this later. Next slide, please. So we're now going to hear from our patient research partners in a short video.
Hi, I'm Suzanne Grieb, a patient research partner from the United States. I first began experiencing psoriasis about 20 years ago and was diagnosed with psoriatic arthritis in 2014.
Hi, I'm Wendy Olster, a patient research partner from the Netherlands. I had my first symptoms when I was 14 years old and was diagnosed with psoriatic arthritis about 3 years later.
So we both had a considerable gap in time between our first symptoms and our diagnosis. What was your disease history and diagnosis like in the Netherlands?
Yeah, so my diagnosis with psoriatic arthritis was not easy. I was just 14 years old when I began having a lot of pain in my hips and in my neck. And I visited a lot of pediatricians and orthopedics, but none of them could really figure it out. They even told me I was too young to have a type of arthritis. And then a few years later, I finally visited a rheumatologist who diagnosed me with juvenile arthritis, as the joint cartilage of my hip was broken down due to all the flares. It was such a relief to finally get my diagnosis. And a bit later, I also started to develop psoriasis around my elbows, and they diagnosed me with psoriatic arthritis. So, Suzanne, our situations are quite different in regards to the order of symptoms. How was your psoriatic arthritis finally recognized?
Yeah, so I had seen multiple dermatologists over the years for my psoriasis, but had never heard of psoriatic arthritis. And over the years, I had a lot of pain in my feet, probably starting in my late teens and early 20s. And then after I had my son, I started experiencing really bad flares on my skin, extreme fatigue, leg pain, and then my postpartum depression turned into chronic depression. And through work, I just happened to be invited to conduct focus groups with psoriatic arthritis patients for a rheumatologist at my institution. And during these focus groups, I realized that these patients were describing my situation. And so I then saw a rheumatologist and was diagnosed with psoriatic arthritis. And it was all a bit surreal because previously we had been dealing with everything individually. And it was almost mind blowing to me that my issues uh, were connected and that there was some underlying cause that could address them because this had never been suggested to me. And so our stories are somewhat switched in order, but they do share like this issue of disconnect. Looking back on your experience, what do you think the trouble was with sorting your psoriatic arthritis out, and how would you like to see the diagnostic process improved for others?
So for me, it would have helped if there was a more holistic perspective between doctors, including rheumatologists and orthopedics and also dermatologists. I think if there was a better multidisciplinary approach, they would have diagnosed me sooner. And if I got the treatment earlier, I also wouldn't need the hip replacement that I need now.
Yeah, I agree. I would say the lack of the holistic perspective or system really hindered my experience as well. Um, Part of that is just a result of the US healthcare system, but greater education around psoriatic arthritis, I think, could at least help some.
Yeah, I totally agree. My doctors dismissed the idea of arthritis because of my age, and I think greater education could resolve this. Thank you all for allowing us to share our stories and experience as patient research partners.
Thank you.
Hello. This presentation concerns the clinical features classification and epidemiology of psoriatic arthritis. Psoriatic arthritis was first defined by John Moll and Werner Wright in 1973. They described the association of an inflammatory arthritis with psoriasis, and cases were usually negative for rheumatoid factor, not anti-CCP of course at that time. I worked with Werner Wright for many years, and he often looked for other associated features before making a diagnosis, including, as you see here, spondylitis, enthesitis, dactylitis and so on. But these weren't explicitly stated in the clinical features and definition that they put together in 1973. Psoriatic arthritis usually follows the onset of psoriasis, but in a few cases It can occur simultaneously with the onset of psoriasis, and occasionally it will precede the onset of psoriasis. Werner Wright and John Moll described 5 subgroups within their original definition: a symmetrical polyarthritis, an oligoarthritis, arthritis mutilans, distal interphalangeal predominant, and axial disease, and roughly in the percentages that you see quoted here. What they didn't do was also quote the percentage involvement of patients with dactylitis and enthesitis, again 2 key clinical features of this condition. And nowadays we probably regard the presentation of psoriatic arthritis as roughly equal between oligoarthritis and polyarthritis, but it does vary slightly from in different series. So in 2006 we published the CASPAR criteria. Prior to this, the original Moll and Wright definition had led to some confusion, and I think this happened because they didn't include those key clinical features that I described in a couple of slides ago. The CASPAR criteria helped better classify psoriatic arthritis and have been used since in most interventional and epidemiological studies. And the CASPAR criteria require a patient to have inflammatory articular disease either in the joints, entheses, or the spine, and in addition to fulfill the following features. So if a patient has current psoriasis, they need only one other of the following features: dactylitis, nail disease, a negative test for rheumatoid factor, or radiological evidence of juxta-articular new bone formation. But a patient can be classified as having psoriatic arthritis without having psoriasis currently. And as you can see, with a personal or family history of psoriasis and 2 of the following features, that classification is possible. And indeed, a patient can be classified in the absence of psoriasis, personal or family history, if 3 of the features noted in the yellow box are present. And CASPAR criteria have really helped us in studies of psoriatic arthritis since their publication in 2006. Obesity is a risk factor for developing psoriatic arthritis, and in this data from a UK GP network, you'll see there's an almost dose-response relationship. And more recently, it has been shown that people who manage to lose weight will reduce their chances of developing psoriatic arthritis, thus making this a modifiable risk factor for the development of the disease. There are a number of studies that have looked at environmental exposures, and one of these in the past has been injury, from personal injury to car accidents to heavy lifting, that have shown a higher chance of developing psoriatic arthritis. Infections have also been identified, but the question of smoking remains controversial. Originally, it was thought that smoking was a protective factor for developing psoriatic arthritis, but if you look at most studies in more detail, the association between psoriatic arthritis and smoking could go either way. Some people have reported no association at all, others a positive association, but I think there were some methodological problems with such studies, and others have reported negative association. So I think the jury is out on that, although if you want my personal opinion, I would favour the negative association. Although the prevalence of psoriatic arthritis in a population with psoriasis is about 20 to 30%, the incidence rate is of course much less, and this prospective study from Toronto shows an annual incidence rate of about 2.7%. The population incidence of psoriatic arthritis is of course much less, And these studies show attempts to define this worldwide, with the lowest incidence being in Japan and China. But of course it will also depend on the criteria used, and since 2006 we've been using CASPAR, as you can see, and these were probably more reliable figures. Worldwide prevalence figures for psoriatic arthritis are of course much higher. Note in this slide these figures are per 100 persons rather than 100,000 persons. And again, lowest prevalences are seen in China and Japan, but there's reasonable consistency elsewhere. And please note, we don't have any reliable data for Africa at the present time. So moving on to the clinical subtypes of psoriatic arthritis, the commonest type that we see probably presenting is polyarthritis. This can be both symmetric and asymmetric depending on the number of joints involved, but can look like rheumatoid in the sense of involving the small joints of the hands, feet, wrists, ankles, elbows and knees. And generally speaking, the more joints involved, the more severe the disease and the worse the prognosis. So I think that's worth noting, that if a patient does present with a lot of joints involved, then these are the patients that should be targeted for early and aggressive treatment. However, about 50% of patients do present with oligoarthritis. It's asymmetric by definition, may involve large joints like one knee, an elbow, an ankle, but also isolated finger or toe joints, and may well be associated with isolated dactylitis, so-called sausage digits, in which there's nail involvement. Dactylitis is a hallmark clinical feature of psoriatic arthritis. It's seen more commonly in the foot than the hand, and on MRI studies, inflammation is seen throughout the digit, not only the joints but the entheses, the bone, the tena synovium and even soft tissue. So this is a true inflammatory process of the whole digit when it is seen. Enthesitis is another hallmark clinical feature. There are hundreds of enthesitis points around the body. The commonest involved, as we'll see in a minute, is probably the lateral epicondyle and Achilles. And the Achilles is probably the easiest and largest enthesis in the body. And I always teach that this is the one that should be examined, if any, when looking for enthesitis, because it's easiest to find, to examine, and also to discover inflammatory features. Again, the Toronto cohort has looked at the incidence and prevalence of enthesitis based on the SPARC index and found an annual incidence of 0.9% with a mean number of sites of 2. And as I said, the commonest sites were the Achilles and the lateral epicondyles, which sites are common to both the SPARC and the Leeds enthesitis index. And enthesitis is, again, an adverse prognostic factor and is associated with inflamed joints, dactylitis, pain, but less clinical damage in the Toronto cohort. And risk factors for developing enthesitis include a high BMI, actively inflamed joints, and a younger age. Very few people have pure axial involvement, but up to 40% may have axial involvement along with their peripheral joint involvement. And axial involvement in psoriatic arthritis may be quite heterogeneous, with cases that look like classical ankylosing spondylitis, and others that look atypical with a lot of asymmetry, less sacroiliitis, less B27, and a different morphology of syndesmophytes. Isolated distal interphalangeal involvement is unusual and is often associated with nail disease. But when it's isolated, the main problem is distinguishing psoriatic arthritis from primary osteoarthritis, and the next slide will go into this a little further. It is difficult to distinguish isolated DIP joint involvement in psoriatic arthritis from primary osteoarthritis, particularly if there are no other joints to help. Nail involvement with psoriasis is a key feature here and is used to help make that distinction. And inflammatory soft tissue changes will help as well. But essentially we're relying on radiological change to help make that distinction. And I will go into these briefly in the next slide. From a radiological point of view, the two key features that distinguish psoriatic arthritis from osteoarthritis, favoring psoriatic arthritis, is severe osteolysis, as you'll see here, and copious juxta-articular new bone formation, as you will see here in this lower figure. Arthritis mutilans is a rare variant of psoriatic arthritis and involves severe osteolysis of the digits, resulting in telescoping of the digits, as you will see here. I think this is probably a variant of the disease that is becoming less prevalent, and this may be associated with more aggressive treatment, but we don't know that at the present time. Nail disease is an important manifestation of psoriatic arthritis, not only from a diagnosis and classification point of view, but also as a risk factor for the development of psoriatic arthritis in people with psoriasis. Generally speaking, there is little difficulty in distinguishing psoriatic arthritis from, say, ankylosing spondylitis or rheumatoid arthritis. But there are occasional difficult cases, particularly, for instance, if there's low titer rheumatoid factor or anti-CCP in the serum. And we know that 7 to 10% of our cases with psoriatic arthritis may have these antibodies. So sometimes we have to rely on associated clinical features, as I've listed here, and in particular on radiological appearance. The difference between rheumatoid arthritis and psoriatic arthritis is usually quite striking, with periarticular swelling and osteopenia very prominent features in rheumatoid arthritis, whereas in psoriatic arthritis the osteopenia is not prominent at all, and there's periarticular and juxta-articular new bone formation which can distinguish between the two. So in summary, psoriatic arthritis is a clinically heterogeneous condition that can present with many clinical manifestations. We are always interested in a family history of psoriasis or psoriatic arthritis and of the joint distribution, particularly the involvement of distal interphalangeal joints. Dactylitis is usually a giveaway clinical feature, as is nail involvement, because this is a common associated feature of psoriatic arthritis. There's usually absence of antibodies to rheumatoid factor and CCP in the serum, although, as I've just said, low titer antibodies can be occasionally found. In the spine, we're looking for less symmetric disease, although classical AS can be an associated feature. And as I've just pointed out, the X-rays may be quite different between, for instance, an inflammatory arthritis such as rheumatoid and that seen in psoriatic arthritis. So overall, the clinical, serological and radiological appearance must be taken into consideration. We had before the presentation. So if we move to the first question, which I thought most of you answered pretty well anyway. So again, which of the following statements is true about enthesitis in psoriatic arthritis? And you've got the 5 options here. As I said, there may be more than one are true, prevalent in about 1/3 to 1/2 of cases. Clinical assessment reliably correlates with imaging. Enthesitis is always the clinical manifestation of this disease. Tenderness at multiple enthesitis points may cause confusion with fibromyalgia, and enthesitis is most commonly seen around the knee. So please vote now. You probably already have done. I'll give you 3 seconds here. 3, 2, 1, and I'll close the poll now. And yes, the 2 correct answers here are the prevalence question about 1/3 to 1/2 and the confusion with fibromyalgia. So well done. There are the highlighted. Good voting there. Next question: psoriatic arthritis and dactylitis. Is the pathology tenosynovitis, bone edema, synovitis, enthesitis, or all of the above? Please vote now. 3, 2, 1, and I'm closing the poll now. And there's still some diehards hanging on to pure T synovitis, spectral one or two enteritis, but the majority of you, I corrected that it's all the above. Thank you. So now we'll move on to the panel discussion. And on the panel, there'll be myself, Wendy, one of the patient research partners you've just seen presented, Laura Savage, a dermatologist from Leeds, and Dennis Dubney from Berlin. So we've already had 1 or 2 questions. The first questions concerning obesity and association between obesity and development of PSA. And I guess psoriasis, that's true, isn't it, Laura, that it's a risk factor for psoriasis. So the question was, what could be the mechanism between obesity and incidence of PA? Well, there is the further seminar on pathogenesis that you'll probably get more answers to, but a number of explanations there. Obesity obviously is a common accompaniment of psoriasis and psoriatic arthritis, and is an appropriate co-disease. Obese tissue secretes inflammatory cytokine, be a clue. Also, obese people will be more strain on their joints and tendons, so there may be treatment via a draw in that way. What is you, Laura? Do you need any on the relationship between obesity and psoriasis?
Yeah, I think for us it's the fact that patients who are heavier simply have more adipose tissue, and that in itself is more pro-inflammatory, and then we tend to see that they have difficult to treat more severe psoriasis. As for sort of joint underpinned mechanisms, again, I think it's to just do with this psoriatic march and systemic inflammation. We don't perhaps have the same stresses on the joints as you would in PSA, which would account for the potential additional wear and tear of the joints that you may see in heavier patients developing PSA. And it's a bit chicken and egg, isn't it? Which comes first? Is it the obesity, then the psoriatic disease, or the psoriatic disease causing obesity? Dennis, what are your thoughts, particularly from a joint perspective?
Yeah, I think what you mentioned is all right. So probably there are many components on that, including pro-inflammatory stimuli coming from the fat tissue, adipose tissue, but also from purely mechanical perspective, more weight means more mechanical load, and we know that mechanical load is a key factor in the pathophysiology of enthesitis. Without mechanical load, there would be no enthesitis at all. It might be a link towards psoriatic arthritis association with obesity.
And the good news, I guess, is that if you lose weight, you have a chance of developing psoriatic arthritis. So if you've got patients with psoriasis, this is a good stimulus for them to lose weight. And of course, no one in the Netherlands is overweight. That's true, isn't it, Wendy? You're all bicycle riders, so that you don't have this problem in the Netherlands, I guess. Okay. We have some other questions here. Katie Leung from Singapore has put a comment in about smoking and arthritis. That incident obesity, because smokers are typically more slender thinkers. This negative association being explained by the lower body weight. There's another question here asking why, my opinion, do certain joints become involved and not others in psoriatic arthritis? It's certainly true of oligoarthritis. A knee or an elbow, as I said, just on a finger joint. And the answer again is clear, but I suspect there may be something to do with trauma. Or for instance, if you look at the pattern of dactylitis, it's commonest in the right finger of the hand, the right hand in particular. And this is the finger that makes more straight, of course. My finger I use most in my working and things like that. So it could be that trauma is the pattern, but I can't think that that's the whole explanation. We have another question. Enthesitis. As mentioned, there is some often confusion in identifying enthesitis, and we know that there is very poor correlation between ultrasound and clinical enthesitis. So the question that has been put is, what could be the perfect solution to differentiate between enthesitis, the MRI or ultrasound? I think the jury's out. Ultrasound and MRI for me, you should see a lot more with ultrasound. We need more certificates. What I would say is that if you think that you're reliably identified at the point in the body when you're pressing your thumb against them, I think we have to be careful not to make that decision. Unless maybe with the Achilles tendon insertion, which is probably, as I said on the video, the biggest enthesitis and the most accessible, and the one I always recommend my dermatology colleagues to look at when they're examining patients. I have a question here. Wendy, come in for one of the patients. You developed psoriatic arthritis as a young person. The question is, do you think the impact of psoriasis is different in young people than when it comes in adults?
Yeah, for sure. I think it's totally different when you're young. I was 14, as you saw in the video, which is quite a young age to develop psoriasis and also psoriatic arthritis. And I think it's really the age where you are developing yourself and developing your self-confidence. And it's really hard because if you have the psoriasis, it can be really disturbing, and you almost feel like you're ugly. And especially when you're young, I think it's really something on your self-confidence compared to when you're older. I think then it's already built and you can handle it much better. So I think that's something to keep in mind as well, that young people, they might have some more trouble with it than older people.
Well, Wendy, can I ask you, what strategies have you developed over the years to help you cope with the sense that people are staring or looking, or, do people ask questions? Do they not? Are you happy to educate people? What's your
to be honest, I'm quite lucky that my psoriasis is under control now, but with my hip, because of the psoriatic arthritis, it was totally broken down, like the cartilage, so I was limping a lot. Which was quite disturbing, and people were always looking at me like, oh, what she's walking like that and why? And especially when I was in high school, they never asked me questions. They just started bullying almost. But I will always fight back, and my mom always told me if someone's bullying you, you should bully them back. So I think it's something you develop over the years to get your confidence about that. But especially in the beginning, it's hard because when you have no diagnosis, also as you saw, it took 3 years.
Yeah.
And then if you don't know what's going on, and you really want to have a fast diagnosis so that you know what's going on, and you can also tell them like, yeah, I'm really sick, and it's just nothing that's going on with me.
Yeah, the knock-on effect of that, I suppose, is that I see many of my patients with, particularly obviously in my clinic with psoriasis, who are alexithymic. They are almost unable to share their feelings. They avoid questions about how they are because of many years of feeling so self-conscious or experiencing, people staring, looking, but not asking. And I think that's that's it, isn't it? It's having the confidence to step forward and say, hang on, I'm not well. This is
Yeah.
not my fault. This is not, how I am.
Yeah, I can help doing it. Yeah,
Exactly.
there.
Philip, are you back with us?
Can you hear me, Bill?
Not so clearly, Philip.
Okay. Well, I was going to move on to the next section if everyone can hear me.
Okay.
Let's move
All
on.
right. Let's move on now to psoriasis, the psoriasis aspect of psoriatic disease. And I just give you 2 questions, as we did before. So the first question for psoriasis is, which of the following is a dermatologic emergency? Is it severe intertriginous psoriasis, widespread cutate psoriasis, severe nail psoriasis, or erythrodermic psoriasis? So please vote now. I'll give you 5 seconds to vote here. 5, 4, 3, 2, 1. And please end the poll now. So we have a mixture of responses, but most people have gone for erythrodermic psoriasis. Thank you. Next question, please. Next question concerns palmoplantar pustulosis. Which of the following is a feature of palmoplantar pustulosis? Predominant keratotic on the palms and soles, associated with HLA-CW6, associated with heavy alcohol intake, or plaque psoriasis in about 20% of cases. So please vote now. 5 seconds. I'll give you 5, 4, 3, 2, 1, and we'll close the poll now. So the majority of you voted for the predominance of hyperkeratotic plaques on the palms and soles, and a few associated with plaque psoriasis. So I think you're quite a savvy audience, but we'll see when we come back to these questions after the presentation, which will be given by April Armstrong, Professor of Dermatology from Southern California.
Hello, I'm Dr. April Armstrong. I'm Professor of Dermatology and Associate Dean at the University of Southern California in Los Angeles. I'm very excited to talk to you today about psoriasis, focusing on its epidemiology, classification, and clinical features. I run our department's clinical studies unit, and here are my disclosures. Let's start with a question. Here are 2 patients. One of them has psoriasis. Can you correctly identify which one? If you identified person A on the left as having psoriasis, you're correct. Person B on the right has leprosy. The diagnosis of psoriasis can be confusing in some cases. In fact, if we lived in Roman times, many psoriasis patients would be sent to quarantine at leprosy colonies. Compared to psoriasis, leprosy lesions tend to be less scaly. And, as you heard from our patient research partners Suzanne and Wendy earlier, the impact of psoriasis and psoriatic arthritis is substantial. Therefore, accurate diagnosis and classification of psoriasis is highly important. Today, we will discuss epidemiology, pathogenesis of psoriasis. We will also identify psoriasis subtypes and common clinical presentations. Finally, we will provide a brief overview of the comorbidities associated with psoriasis. Approximately 125 million people around the world has psoriasis, and its prevalence varies depending on the region. Psoriasis prevalence is highest in Western Europe, followed by Central Europe, North America, and South Latin America. Psoriasis prevalence is relatively lower in East Asia and Australasia. In the United States, where I live, Psoriasis affects approximately 3.2% of the US adult population and less than 1% of children. That amounts to approximately 8 million people affected with psoriasis in the United States. The prevalence rates of psoriasis in Europe and Russia vary between 1.5 to over 3%. Psoriasis prevalence in Africa is not well characterized and is thought to be below 0.5%. In Asia, the prevalence rates are estimated to be 0.4%. Psoriasis occurs in equal frequency in both sexes. 75% of patients will have onset of psoriasis before age 40. In adults, there are two peaks of onset. First one between 20 to 30 years of age, and that's the most common type. Most people who present with psoriasis in adulthood will present during that peak. There is a peak later on at between 50 to 60 years. In children, the onset is typically between 8 to 12.5 years. The prevalence is between 0.5 to 1% in children below 16 years of age. Psoriasis has a strong genetic basis. Here are the various HLA subtypes that have been associated with psoriasis. Notably, HLA-CW6 confers a high risk of developing psoriasis in Caucasians and the Japanese. HLA-B26 has been associated with pustular psoriasis, and HLA-B13 and B17 have been associated with guttate psoriasis in children. Based on this classic European study on families with psoriasis, if both patients have psoriasis, a child has 50% chance of developing psoriasis. If one parent has psoriasis, a child has 15% chance of developing psoriasis. So, what is going on in the skin? This JAMA review paper that our team published talks about the pathogenesis of psoriasis. Overall, psoriasis is based on a feed-forward inflammatory model. Myeloid dendritic cells are critical in this process. Once activated, they migrate to the lymph nodes. There, they secrete IL-12, which enables differentiation of naive T cells into Th1 cells. Or the myeloid dendritic cells can also secrete IL-23, which is highly important in psoriasis. IL-23 is critical in the differentiation of naive T cells into Th17 cells, which then secrete downstream cytokines such as IL-17 and TNF-alpha, among others. These inflammatory cytokines further drives and perpetuates this inflammatory cycle, which leads to keratinocyte proliferation and infiltration of lymphocytes and neutrophils. Exogenous triggers and exacerbating factors of psoriasis include infection, especially with streptococcal infection, hypocalcemia, psychogenic stress, certain medications, as well as obesity, alcohol consumption, and smoking. Now, let's talk about the important topic of different subtypes of psoriasis. The classification of psoriasis can be either based on morphology, what the lesions look like, or based on location, where they are on the body. Using the morphology-based classification of psoriasis, plaque psoriasis is the most common subtype. Other subtypes include guttate, erythrodermic, and pustular. Dermatologists also use location-based classification, referring to subtypes as inverse or intertriginous psoriasis if they occur in the skin folds, palmar-plantar areas, or nail psoriasis. It's very important to recognize two features of these classification systems. First, there can be overlap of morphology-based and location-based classification in the same individual. For example, a patient may have plaque psoriasis on the arms and inverse psoriasis. Second, a patient can also change from one subtype to another, for example, from guttate to then progressing to plaque psoriasis. So it is important to recognize this fluidity and don't get yourself frazzled if you cannot put a patient neatly in one subtype. Now, Let's talk about plaque psoriasis. Plaque psoriasis is the most common subtype of psoriasis, representing approximately 80% of the phenotype. It is characterized by well-demarcated plaques with varying degrees of erythema, scale, and induration. Does psoriasis itch? It can, especially in patients with extensive plaque psoriasis or plaque psoriasis involving the scalp. Gouty psoriasis presents with eruptive confetti-like 3 to 5 millimeter patches on the skin. It commonly occurs following streptococcal pharyngitis. Gouty psoriasis may progress to plaque-type psoriasis. Gouty psoriasis occurs more commonly in children than adults. Before the onset of gouty psoriasis, there's often a history of infection with group A beta hemolytic strep of the pharynx and occasionally of the perianal area. In kids especially, gouty psoriasis is associated with streptococcal infection, and this association may be a good thing because when it's associated with streptococcal infection, it is more likely to spontaneously clear than those without the association with streptococcus. Erythrodermic psoriasis refers to confluent red skin due to psoriasis. Patients typically present with warm red scaly patches covering almost the entire body surface area. It is important to consider differential diagnosis for erythroderma, which include drug reaction, cutaneous T-cell lymphoma, or atopic dermatitis. Erythrodermic psoriasis is considered a dermatological emergency because patients can experience alterations in body temperature, fluids, and electrolytes. Pustular psoriasis typically presents as sterile pustules on the background of red skin. Pustular psoriasis can be divided into localized or generalized subtypes. Localized subtype can occur on the palms and soles. Generalized pustular psoriasis, or GPP, is a rare and serious skin disorder that presents with acute flares of widespread pustules. This is also a dermatologic emergency. Typically, the skin is fiery red at first, and then within hours, 2 to 3 millimeter pustules appear. There may be associated fever, chills, myalgia, electrolyte imbalance, and high output cardiac failure. GPP was found to be associated with recessive IL-36 receptor gene mutation. Because GPP can be life-threatening, hospitalizations are generally required to manage body temperature, electrolyte imbalance, and fluid loss. Before we talk about location-based classification, let's take a look at this chart showing the distribution of psoriatic lesions on the body. Not surprisingly, scalp and extensor surfaces are commonly affected. Genital areas can be affected in 33 to 63% of patients. Inverse psoriasis can occur in about 1/3 of the patients, and palmar-plantar psoriasis is present in about 12% of patients. For example, extensive scalp psoriasis can extend along the hairline, as you can see in these two photos. Inverse or intertriginous psoriasis involve the skin folds, such as inguinal, perineal, genital, intergluteal, axillary, or inframammary regions. Because it involves the skin folds where it is more moist, inverse psoriasis or intertriginous psoriasis presents with smooth, shiny plaques with absent or minimal scale. Inverse psoriasis is oftentimes mistaken for fungal infections. Palmar-plantar psoriasis is an entity with varying morphology. The most common subtype presents with thick, hyperkeratotic plaques. The pustular variant, called palmar-plantar pustulosis, has incited some controversy in terms of its classification. While some consider this to be a subtype of palmar-plantar psoriasis, it is regarded by many as a distinct entity from psoriasis. This is because palmar-plantar pustulosis is not associated with HLA-CW6, which is the main genetic determinant of plaque psoriasis. Palmar-plantar pustulosis is strongly associated with tobacco use and can be very challenging to treat. However, it is associated with plaque lesions of plaque psoriasis elsewhere in about 20% of patients, and therefore it is considered by some as still a part of the spectrum of psoriatic disease. Here are some photos of the palmar-plantar psoriasis, the hyperkeratotic subtype. Psoriatic nail disease has a prevalence of around 50% among patients with psoriasis, but some studies suggest a higher prevalence. Nail psoriasis may be associated with psoriatic arthritis, and the treatment of moderate to severe nail psoriasis oftentimes requires systemic treatments. Pitting is the most common psoriatic nail finding. This is a manifestation of psoriasis affecting the nail matrix. However, pitting can also be seen in other diseases, such as alopecia areata and atopic dermatitis. When you see numerous pits, for example, greater than 10 pits on 2 nails, that is more suggestive of psoriatic nail disease. Oil spots are more specific for psoriasis. When psoriasis affects the nail bed, it results in separation of the nail plate from the nail bed. This then results in a yellowish discoloration that looks like an oil spot. In severe cases of psoriatic nail disease, crumbling of the whole nail plate can be seen. Finally, one area that is important to know is that psoriasis is independently associated with a number of different comorbidities, including psoriatic arthritis, cardiovascular and cardiometabolic diseases, depression, and other immune-mediated diseases, such as uveitis and inflammatory bowel disease. Screening for these conditions is very important in patients with psoriasis. With that, I hope that you have found this talk on psoriasis epidemiology, classification, and clinical features to be informative. Thank you very much for your time.
Questions now. So the questions again, as you recall, which of the following is a dermatological emergency? Is it severe intertriginous psoriasis, widespread guttate psoriasis, severe nail psoriasis, or erythrodermic psoriasis? Again, 3 seconds to vote for this. 3, 2, 1. We'll close the poll now. Thank you. And as you just heard, of these choices, erythrodermic psoriasis is the dermatological emergency. Next question, please. So the next question was about palmar-plantar pustulosis. Which of the following is a feature of palmar-plantar pustulosis? Is it predominance of hyperkeratotic plaques on the palms and soles? Is it associated with HLA-CW6? Is it associated with heavy alcohol intake? Or is it associated with plaque psoriasis in about 20%? And there may be more than one correct answer. So vote now. I'll give you 3 seconds. 3, 2, 1, and close the poll now, please. So, as we just heard, the 2 correct answers here were predominantly plaques on the palms and soles, and associated with plaque psoriasis. Or perhaps I'm wrong with that. I do apologize for that, because the confusion that April made, the distinction that April made was between palmar-plantar pustulosis and palmar-plantar psoriasis, in which the predominance of hyperkeratotic plaques are found on the palms and soles. So I apologize about that, and no doubt Laura Savage will pick me up on that very shortly as we move to the discussion. And I also apologize for my lack of sound earlier on. I'm hoping you can all hear me now.
We can, Philip. We can hear you fine now.
Thank you.
Thank
Much
you.
better now.
Good. Well, so I have one or two questions in already for Laura Savage about dermatology. It's a question here, Laura. Can fungi coexist with nail psoriasis? I find it difficult to distinguish between the two, especially in the toenails.
Yeah, you're absolutely correct, Philip. So, you know, fungal nail infection can affect all of us, but certainly if you have lifted and crumbled nails, then it's a greater portal of entry for fungal organisms. We tend to assess nail psoriasis in the fingernails. I tend to look at the toes a lot less because of the potential for coexistence of fungal nail infection. And I'd say probably around a third of my patients who have nail psoriasis will also have fungal nail disease. And therefore, if you have got some yellowing and crumbling of the nails, it can be very difficult to distinguish, I agree, which is fungus and which is psoriasis. Of course, if patients have plaque disease elsewhere, then you would hope that, albeit slowly, their nail disease will improve if it is psoriasis. But of course, if you are left with residual crumbling and signs of onychomycosis, then it would be reasonable to then go on and treat for fungal nail infection as well.
Thank you.
If I could jump in.
You can jump in.
Course,
Thank you, Dennis.
Laura, we have a paradoxal side effect of anti-TNF treatment in form of psoriasis, more frequently rare forms like palmoplantar pustulosis. And I think the pathophysiology is related somehow to overproduction of interferon by overstimulated T cells.
Yeah.
But, are you aware of a similar reaction related to other biological drug classes like IL-17, IL-23 blockers, rituximab, IL-6 blockers? Can we expect similar side effects there as well?
Yeah, so we tend to see that much less. Whenever we do see, paradoxical disease, it does tend to be with those TNF inhibitors, and almost like you say, you get a sort of phenotypic switch, and then it drives forward the other, cytokines that are involved in psoriasis. Particularly with TNS, you've got to be careful with palmoplantar pustulosis. So not palmoplantar psoriasis that should improve, but that is one site where we do tend to see the greatest amount of paradoxical reactions. Of course, it can be very difficult to try and determine whether it is a worsening of psoriasis or it is a paradoxical reaction. And particularly if patients have, say, axial disease, it's quite a difficult call to make for me as a dermatologist to say, yes, I'm convinced that this is all paradoxical TNF and take them off their therapy, knowing that their options are relatively limited. So we will try and improve things with a bit of topical treatment, but if it does persist and continue, then often you do need to move away from a TNF. And I'd probably try an IL-17.
Thank you.
Yeah, Laura, the thing about psoriasis is it's such a huge biomarker for us rheumatologists. If someone comes into our clinic with a swollen finger and they've got a patch of psoriasis on the elbow, you're home and dry from a diagnostic point of view, usually. Yeah. But we know the different sorts of psoriasis. How hard should we be looking for psoriasis when a patient comes in to see us? Should we be looking in every nook and cranny? Would a patient know if they had natal cleft psoriasis?
That's a very good point, Philip, and I very much feel for my rheumatology colleagues who are presented with a patient with seronegative arthritis and no signs of psoriasis, because they sort of fall into this no man's land, and it's almost waiting for the emergence of a plaque to appear, and then something small will appear and everyone's peering at it saying, is that psoriasis, is it not? And I think in that situation sometimes there's no harm in doing a biopsy, a skin biopsy, because you'll get very classical features to be seen. We undress our patients and we strongly advocate that rheumatologists do the same. We are all tight for time in consultations, but I do think it's worth just making sure that you've asked patients about all areas, because they're often not aware that they may get psoriasis, as you say, at more hidden sites, such as the flexural areas or particularly the genitals. You know, and these sites, psoriasis looks very different because of the lack of keratinization that can take place. You tend to get more red patches. They can be shiny and moist as opposed to dry and, you know, with a large degree of scale. So whilst I'm not advocating that you examine every patient's genitals, I think it's worth certainly asking them that question, as to say, you know, psoriasis can affect other sites, albeit less frequently than the classical trunk, limbs and scalp, but just asking them to report the development of changes in these areas.
Yeah, I think that this is a reasonable approach, and this is something I'm doing also in my practice. So first, I have to have a clinical suspicion of that, and then I ask question, and then I do a targeted examination if the patient reports that there is something wrong in this area.
I would fully support rheumatologists as well undertaking an assessment of body surface area. You know, not necessarily doing a full PASI score, because that can be time consuming and you know, takes a degree of practice to have a consistent result. But I think, you know, assessment of whether the patient has, you know, looking at their own palm, that's 1% of their body surface area. Do they have 3 or more palms worth of psoriasis collectively? And if so, that then should trigger a conversation with their dermatologists to think about you know, the correct therapy for that patient.
Come in just made for you, Laura. Dr. Salinas asks, thanks for the lecture. Does the use of biologic therapy in early psoriasis prevent psoriatic arthritis?
The $1 million question, Philip. I'd love to be able to give a definitive answer, yes or no. There is a lot of work taking place, you know, in this domain at the moment, and that's something that we all, you know, want to know the answer to. One of my studies that I did as part of my PhD was looking at patients with subclinical asymptomatic enthesitis. Now, you know, we know that patients will have a degree of degeneration of their, you know, their entheses and their joints as a result of mechanical wear and tear, but we did see a higher prevalence in those with psoriasis who had a PASI more than 10 compared to those patients who, compared to healthy controls. And, you know, and when we treated them with a biologic drug targeting IL-12, IL-23, we did see a reduction in the degree of inflammation seen on ultrasound at the peripheral sites, not in the axial skeleton using whole body MRI. Of course, seeing that reduction, we don't know what proportion of those patients were destined to develop PSA in the first place. And you know, it's a big step to make that jump to say that treating subclinical inflammatory changes on ultrasound is going to circumvent the development of PSA. But that said, I'm mindful of the development of PSA, and, you know, it's not an insignificant number of my patients will be affected. It could be 30, 40% potentially. And therefore, I am mindful of trying to choose a monotherapy that targets both skin and joint when I'm making a decision. I'm keen to know your thoughts and Dennis's thoughts about that.
Yeah,
I think we have to move on because you're cutting your axial domain out here. So I would like to talk about this all day as well. We must move on in the limited time, and it's time to look at axial disease now. So thank you all for your contributions, and we'll come back to you when we've had the presentations. Thank you. So here are the pre-questions for the axial disease. The first question is, what is the approximate male to female ratio among recently diagnosed patients with axial SpA? Is it 4:1, 2:1, 1:1, or 1:2? Please vote now. I'll give you 5 seconds. 5, 4, 3, 2, 1. So we have a variety of answers here. So we'll see how this changes after the presentations. Next question, please. The question here, what would be your next diagnostic step in a 53-year-old patient with chronic back pain who's also got acute anterior uveitis, is B27 positive, and has a slightly elevated CRP? So the options are: no further steps are needed, the patient has got axial SpA. Imaging of the sacroiliac joints might help. Imaging of the spine might help. or no further steps are needed, axial SPA can be excluded because of his age. Please vote now. 5, 4, 3, 2, 1. Close the poll. Again, a mixture of answers here, with the most popular one being imaging of the sacroiliac joints. And I'm glad that no one chose the fourth option. So let's move on now to the presentations, which are going to be given by Asim Khan and Dennis Badubny.
Name is Muhammad Asim Khan. I will describe the epidemiology of expa and review its prevalence expressed as a percentage and its incidence expressed as the number of persons who develop the disease per 100,000 individuals. This busy slide shows some of the recent studies from North America and Europe. Please only focus on the bold letters and numbers among the 5 studies that use the ASAS and the modified New York criteria. The prevalence markedly varies, and the numbers that are underlined indicate the prevalence range from 0.3 to 1.3% for expa as a whole, 0.12 to 0.8% for AS, and it is 0.17 to 0.57% for non-radiographic expa. The global prevalence, as determined by a systematic review and meta-regression analysis, shows a wide variation from as low as 0.02% prevalence in sub-Saharan Africa to as high as 0.35% prevalence in northern Arctic communities, while the prevalence in Europe and North America is quite similar. There are many native tribes that live in North America, and they have been studied for the prevalence of AS, as shown on the next slide. Almost a half a century ago, Gofton reported that Haida native tribe living on an island in British Columbia, a province of Canada, has a 6% prevalence of AS, while many of the other tribes listed on this slide have a much lower prevalence. I am very familiar with the last 2 studies, as I was one of the advisors for this US-funded project performed in collaboration with the former Soviet Union. These 2 studies are the best, and they reported a 0.4% prevalence of AS among the Inupiat and Yupik Eskimo tribes that live across both sides of the Bering Sea, and a 0.53% prevalence among the Chukchi tribe in eastern Siberia. This is the global map that shows a 50% prevalence of B27 among the Haida and 40% among the Inupiat and Yupik tribes. Please also notice a very high prevalence of B27 among all these circumpolar communities up north as compared to the rest of the world. Interestingly, there is a virtual absence of B27 and AS among the indigenous natives of unmixed ancestry in South America and southernmost part of Africa and Australia. As a consequence of the European colonization, the current prevalence of B27 is shown in red-colored numbers. Also, please note that the prevalence of B27 in Japan is less than 1%, actually 0.5%. The incidence of AS also directly correlates with B27 prevalence. As a result, AS is very uncommon in Japan with a 0.48 mean annual incidence per 100,000 population that has a 0.5% prevalence of B27. This contrasts with many times higher annual incidence in the other two populations listed on this in this table that also, and these populations also have many times higher prevalence of B27 in their population. Ankylosing spondylitis is more common among men, whereas non-radiographic XPA is more common among women. And also non-radiographic XPA has a later age of onset and a weaker association with HLA-B27. Switzerland has seen a gradually progressive decline in male to female ratio among patients with XPA from a ratio of 2.6 to 1 in 1980 down to 1-to-1 ratio by the end of 2016 as a result of the improving disease recognition and the use of newer disease criteria. The small red arrow on the world map points to 5 to 12% prevalence of HLA-B27 in Indonesia. The 5% figure is for the Chinese Indonesians, and up to the 12% figure is for the Indonesian native population. But ankylosing spondylitis is more prevalent among the Chinese Indonesians. Now we know the answer for this paradox because the native Indonesians mostly possess B2706 subtype, one of the 224 subtypes currently known, and this subtype is mostly disease neutral. In other words, it's not disease associated in Indonesia among the native Indonesians, while the Chinese Indonesians possess the HLA-B2704 and 05 subtypes that are disease associated. In mainland China, B2704 subtype carries even a higher risk for AS than the 05 subtype. B27 also influences the disease phenotype, and the B27 positive patients clinically differ from those that lack B27. In conclusion, there are marked differences worldwide in the prevalence and incidence of XPA. Variation is greatly influenced by genetic factors, primarily B27, and other undefined factors, and the classification criteria used for the studies. And XPA is still under-recognized, especially in women who more often have a non-radiographic XPA form that has a later age of onset and a somewhat weaker association with B27.
Ladies and gentlemen, my name is Denis Podubny. I'm a rheumatologist in Berlin, Germany, and it's my pleasure to talk today about diagnosis and classification of axial spondyloarthritis. I'm sure that you are very well aware of the others classification criteria for axial spondyloarthritis. This criteria can be fulfilled if a patient with a diagnosis of axial spondyloarthritis presents with chronic back pain that started before 45 years of age and has either sacroiliitis on imaging in combination with at least one additional spondyloarthritis feature, or HLA-B27 positivity with at least 2 additional spondyloarthritis features. Importantly, the classification criteria should not be used for the primary diagnosis of the disease, and there are several substantial differences between the diagnostic and classification approaches. Here they are. First, the aim of the diagnostic approach is to establish the diagnosis of a disease in clinical practice. The aim of the classification approach is to define a homogeneous group of patients for research purposes. Therefore, the starting point in the diagnostic approach is a suspicion of the disease with a certain level of pretest probability, while the starting point of the classification approach is an established diagnosis of the disease. Consequently, differential diagnosis or other conditions that might explain patient symptoms are always considered when making the diagnosis, but are not considered in the classification approach. In the diagnostic approach, we consider both positive and negative results of diagnostic tests, while in the classification approach, we only tick boxes indicating positive test results. Finally, the outcome of the diagnostic approach is a diagnosis of the disease with a certain level of probability, while with the classification approach, we receive yes or no answer with a certain level of sensitivity and specificity. The diagnostic approach can be depicted as a diagnostic scale which weighs positive test results against negative test results. Importantly, the weight of a positive result might be different from the weight of a negative result of the same diagnostic test. For instance, definite high-grade radiographic sacroiliitis has a big diagnostic value if it is present. However, the absence of radiographic sacroiliitis has not that much weight because the disease can be at the early stage. Important is also the big black ball here indicating the presence of a more likely explanation of symptoms. Those weights can be expressed in numbers if we calculate positive and negative likelihood ratios of different diagnostic tests as depicted here. It is important to stress, however, that the performance of different diagnostic tests can be different in different settings and is dependent, for instance, on geographic region and referral pathway. Imaging is the only way of objective confirmation of inflammatory affection of the axial skeleton in a patient with clinically suspected axial spondyloarthritis. According to the Euler recommendation for imaging in axial spondyloarthritis, conventional radiography of sacroiliac joints is recommended as a first imaging method if the disease is suspected. If the diagnosis of spondyloarthritis cannot be established after conventional radiography or radiography cannot be applied, MRI of sacroiliac joints would be the next imaging procedure. MRI of the spine doesn't add too much to the MRI of the sacroiliac joints in spondyloarthritis, but might be relevant for differential diagnosis. In the clinical practice, there are two MRI sequences which are normally sufficient to confirm or to exclude the presence of sacroiliitis as a manifestation of axial SPA. The first one is a T2 weighted sequence with fat suppression, such as STIR sequence depicted here. The purpose of this sequence is recognition of active inflammatory changes, bone marrow edema. The second sequence is a T1 weighted sequence, which is helpful in detecting structural changes caused by inflammation, erosions, fat lesions, sclerosis, and ankylosis. For a better depiction of erosions, you might consider including in your routine MRI protocol a special cartilage sequence such as WIPE, and you don't need gadolinium for the detection of sacroiliitis. According to the others definition of positive MRI of sacroiliac joints, active sacroiliitis compatible with SPA is defined as clearly present bone marrow edema that is localized in subchondral bone and is highly suggestive of spondyloarthritis. This definition was developed for the classification purposes, but describes very well our current understanding of active sacroiliitis compatible with SPA. In the diagnostic approach, we also consider structural changes which indicate the presence of inflammation in the past. It might be relevant, therefore, for making the diagnosis. Let me illustrate the diagnostic approach in a real patient example. This is a young male patient, 27 years old, who presented to a rheumatologist because of low back pain for approximately 3 years. There were some features indicative of inflammatory back pain, but no peripheral and no extramuscular skeletal manifestations. HLA-B27 was positive and CRP was only slightly elevated. In this case, we have a young B27 positive subject with chronic back pain and slightly elevated CRP that makes axial spondyloarthritis one of the most likely explanations of back pain. In order to confirm the presence of axial spondyloarthritis, we performed radiography of sacroiliac joints first. This is so-called Ferguson view, normally allowing for depiction of the upper portion of both sacroiliac joints. With the exception of some sclerosis in the left sacroiliac joint, there are no pathological changes here. The next step is therefore MRI of sacroiliac joints, and here you see the stir sequence with bright water and dark fat signals. On this sequence, we are looking for the presence of bone marrow edema. Indeed, bone marrow edema is clearly present here, localized in a typical anatomical area, and is large enough to be seen on several consecutive slices. In order to be sure that this bone marrow edema is really related to axial spondyloarthritis, let's have a look at the T1 weighted. T1 weighted sequence is characterized by the bright signal from fat and dark signal from water. Here we can see structural changes compatible with axial spondyloarthritis, subchondral sclerosis, fat metaplasia, and erosions. On this background, we can be sure that bone marrow edema seen on the previous slide is related to axial spondyloarthritis. In summary, the diagnostic approach in axial SPA is based on a careful evaluation of positive and negative test results in the context of the pretest probability and other potential explanation of symptoms. Classification criteria should not be used for establishing the diagnosis. Imaging for the objective detection of inflammatory changes plays one of the most important roles in the diagnosis of axial spondyloarthritis, and of course, imaging findings should always be considered in the clinical context. Thank you very much for your attention.
Thank you, Dennis, for a very good talk. Now to the questions again. The first question you recall was, what was the approximate male to female ratio among recently diagnosed patients with axial SPA? Was it 4:1, 2:1, 1:1, or 1:2? So please vote now. You have 3, 2, 1 seconds. I'm going to close the poll. And the answer still is very varied, but I think if you were listening to Professor Kahn, he did show a graph where the ratio was approaching 1:1, and that is the correct answer. So next question was, what would be your next diagnostic step in a 53-year-old patient with chronic back pain, acute anterior uveitis, B27 positive, and a slightly elevated CRP? And you have 4 options. No further steps are needed. The patient has axial SPA. You should image the sacroiliac joints or image the spine, or no further steps are needed because AXPA can be excluded because of the age. So vote now, please. Vote in 3, 2, 1, and I'll close the poll. And as we've just heard from Professor Podobny, imaging of the sacroiliac joints would be the next step. So well done. You all, almost all of you got that correct. So let's now move to the final panel discussion, as we have in previous times with myself, Wendy Ulster, Laura Savage, and Dennis Podobny. And I already have a question in here, Dennis, from a patient who says, an attendee who says, recently there have been several reports on the high prevalence of bone marrow edema in the SIJs in runners and even healthy subjects. So what's the specificity of bone marrow edema in the sacroiliac joint, and how can we differentiate mechanically induced edema from that caused by SPA?
Yeah, thank you very much, Philip. It is indeed was one of the major points of criticism regarding the others definition, the others classification criteria in the recent time. So the point is, bone marrow edema in sacroiliac joints is quite specific for axial spondyloarthritis. Quite specific means it has a specificity of about 83–85%, meaning that if you investigate around 100 healthy young subjects, you might see bone marrow edema in 15 to 17%. This is the first point. The second point, how to differentiate. We do know today how to differentiate mechanically induced bone marrow edema from bone marrow edema in axial spondyloarthritis, because mechanically induced bone marrow edema is normally localized in the areas which are subject to mechanical stress. In sacroiliac joints, it will be very anterior, so ventral part of the sacroiliac joint and caudal part, so close to the place of capsule and ligament detachment. And another very important differential diagnostic sign for imaging is an absence of structural damage on MRI. So mechanically induced bone marrow edema is normally not associated with erosive damage. So absence of erosions would be of differential diagnostic value to separate axial SPA from mechanical condition like osteoarthritis, osteitis condensans, ELI.
Thank you. That's great. And questions come in here about the different. We heard from Asim Khan about the worldwide variation in prevalence of B27. And the question is, do you think the same weight will be ascribed to B27 in future criteria, given that most of those patients in the original criteria were from Europe or North America?
Yeah, it's a good question. Currently, we're recruiting the classic study. This is a study that was initiated by North American group Spartan and by international group others. And within classic study, we will have 1,000 patients in total recruited in many countries of the world, including also Arabian countries, Asian countries, South America, where they think that association with B27 is not that strong. And at the end, we'll certainly look at different scenarios. So the idea is to have a specific set of classification criteria. And if there's specificity in this validation study of the existing set will be not good enough, there might a revision of the criteria set is possible, and then possibly a different weight will be given to different spondyloarthritis features. But again, I think we need to differentiate between the classification and the diagnostic approach. So for the classification, it could remain as it is, but for the diagnostic approach, we need to keep these differences in mind for sure. In Europe, for example, B27 has a very high sensitivity and specificity of almost 90% each. In Arabian countries, in South America, the sensitivity is lower and specificity seems to be also not that high.
Thank you very much. And I'm very much aware that we're running out of time here, and I'm not ignoring you, Laura, but we are time limited. I want to give the last word to Wendy, but one quick question, if that's possible, Dennis. A question's come in about non-radiographic axial SPA. How can you predict those who are going to go on to develop radiographic axial SPA? Are there any clues there? And if you could make it as brief as you can, thank you.
Absolutely. High inflammatory activity. So a lot of inflammation on MRI, high level of CRP are strongest predictors of progression to radiographic stage, frequently within several weeks to months.
Thank you very much for that very brief answer. And finally, Wendy, I have to ask you, you gave a story of a long period before you were diagnosed, and you mentioned that maybe better interdisciplinary working could have made that sooner. Any other ways, do you think, raising awareness of this disease in patients as well as professionals would help?
Yeah, I definitely think so. I think radio education is really important. I was just, because you discussed that before, but when I came in to the doctor's office, I only had pain in my joints, and it took them about a year, I think, before they even asked if I had anything else or looked at my nails, although I had psoriatic nail disease. So I think it's really important to be aware of that and have the whole image of the patients and really look at everything instead of ignoring some certain parts, because we might not be aware as well. So if you ask us, oh, do you have anything else, then we might not be aware that it belongs to it as well.
Thank you for that. Well, thank you, everybody. I'm going to close now, and I'd like to thank all the discussants and the speakers for their contributions today. I I'd like to thank the audience for your questions. I'd like to thank Pfizer for their support. I'd like to thank Nucleus for their efficient support, and also Lisa from Spartan and Janine from Grappa. There are other seminars coming up, as you will see on this slide here, over the course of the next few months, and you're welcome to register and join those. The presentations you've seen today will be available on the Grappa and Spartan websites soon. And please, if you're interested in psoriatic arthritis or ankylosing spondylitis, axial SPA, please join our associations. You'll find more information on that on the appropriate websites. So thank you for attending, and I wish you all a very good day.